Thank you very much for inviting me. I think I've done this 3 years ago. Few things changed. I'm not sure how much pump technology had been in Egypt. But just answer a question by a raise of hand. Who knows a patient or treat a patient on insulin pump? None. So it's really. So I'll try not to concentrate on the science. More of a I was asked to speak more of a practical aspect. How do you work with insulin pump? How you interpret the data? How do you use it, and how you use the sensors? Thank you. Starting here, just showing despite type 2 diabetes is a complex disease, but really it is still a big part of it is a beta cell failure. Why is that important slide? Because when we talk about insulin pump, it's not only for type 1 diabetes, it's indicated also for type 2 diabetes when they get to the stage when they're here, where they lost 90% of the beta cells, and now patients with type 2 which act just like type 1. And different what we just heard about the LDL, it looks that the A1C is definitely not the lower the better. The more, we thought that maybe 10 years ago, but with more and more evidence showing that depending also on being on oral agents or insulin plus oral agents, it's a J curve. And the risk of mortality is at a certain point with high numbers, but also can be with lower numbers. One of the reasons for this, it is not only the A1C. A1C is an average, but if the average is all low and high, and this is how you read a sensor. This is a continuous glucose monitor. This we have 30 or 50 in our office, and we put them in everybody to get data. This is similar A1C, but you can see the difference. This person has sugars in the 30s and 400. This is, of course, still not controlled, but these patient risk is completely different because there's something called glucose variability. You can spend an hour, ACE has probably 100 slides of glucose variability and risk of heart disease. So it's not the A1C alone that predicts cardiovascular disease, and we show that with all the newer trials, like Accord and VA trials. The lowering the A1C at a certain level did not improve cardiovascular disease. One of the factors were glucose variability, and again, we have tons of evidence on this, just we don't have the time to talk about it. So in order to give patient the same insulin as the normal body, the normal pancreas will give insulin. We know this basal bolus, of course we all know this, and we have so many different insulin work different times of the day and regimens. But why do we need these? These are all newer pumps, and there's probably around 18 different pumps now. We'll be glad China is getting into this market, and we're talking about cheap pumps. I think that's what we need, that's future pump. But in general, the idea that pumps will be coming more and more, be easier, and hopefully will be cheaper, it will be available in the rest of the world. According to ACE, some type 2 diabetic, if they are on 4 injections, still uncontrolled, they still can qualify for type 2 for a pump. And these are the indications for type 1 diabetes. So you can say pretty much anybody, uncontrolled, frequent hypoglycemia, that's a big factor. Hypoglycemia, unawareness. Pregnancy, we work with OB, pretty much every single gestational diabetic come to our office and gets on the pump throughout the pregnancy, and they're showing data that improve the outcome. The extreme insulin sensitivity, where patient they can take half a unit more or half a unit less, and it can be a big problem with the sugar. Sometimes that's the macrovascular complication. In a way, pretty much anybody with type 1 diabetes could qualify for the insulin pump, and we have probably hundreds of slides and showing that the evidence that people on insulin pump do better in terms of outcome and risk compared to multiple injections. So what is the difference? What do we achieve with insulin pump for diabetic that we could not achieve with multiple injections? Because of course the cost is a big issue here. One of the factors is when we give insulin as a basal insulin, we give it as a straight line, and we think that our basal secretion of insulin is a straight line 24 hours. That's not true. This is looking at a different age group. Depending on the hormones, we all know that endocrinologists, it's early in the morning when the hormones start coming up. Depending on the age, your basal need of insulin completely different just based on the circadian rhythm of hormones. Now, talking also about different schedules, and we'll come to this and see how can different schedule affect the basal rate. One of the other factors also, sometimes it's frustrated. Patients tell you that they do the injections on time, they do everything's perfect, and it's still, you see the patient take a shot in the morning, his sugar was 50, take the same shot next day, and his sugar was 350. So what happened? Why the absorption is different? Why the results are different? One of the ways is something called intra-subject variability. These are the claim studies done on different insulin. These injections in different days, same patient, same dose, but different days. And you can see here the absorption, the area under the curve is different days. So even in studies where things are controlled, the same injection does not give you the same profile. That means the response rate, that's called variability. That variability can be up to 74% in NPH and as low as 24% in the newer generations of insulin. So this is a big problem. Again, patients doing everything correctly, and this has to do with distribution, the skin, the damage to the skin, the temperature, the needle, the pressure. So many factors affect this. So your patient will be compliant, will do everything right, but you look at their book and the response and say, what happened? Why one morning you are at 100 and next morning you are 200 and you took the exact same shot the night before? The location of the injection, again, the technique and the storage, all be a factor. And that's one of the things we address with the pump. So when you can achieve with insulin pump, again, this is in difficult patients who are on 4 injections a day, and it's still, they may have a nice A1C. The problem with this having high or normal A1C with very low numbers and very high numbers, it really not helping that patient that much. With the basal rate, you can program the basal rate, not if you give an injection of any long-acting insulin, you work 24 hours. But with the basal rate, you can program it every hour different basal rate. For example, we program the basal rate based on your sleep habit, work habit, exercise habit. When do you eat? When you don't eat? When do you exercise? When you don't exercise? When do you work or you don't work? We have people with different schedules. We have patients who their basal needs are different on dialysis day and on non-dialysis day. We have patients that are on different basal regimen on days when they work day shift, on the days when they work night shifts. So workers who work at night, their requirement of basal insulin are different. You can't program that with the pump at a different time of the day. You can come to a certain part of the day and decide, I'm going to exercise for the next 2 hours. So if you already got your basal insulin in the morning, you're stuck with that high insulin. But if you are on the pump, you can down it to 50% or 30% basal rate. And you can exercise with no risk of hypoglycemia. This becomes very important for my patients in Ramadan and fasting, because the type 1 diabetic that insist on fasting in Ramadan, we put them on insulin pump and we manage their basal rate based on the fasting in the day, and it worked very good for them by lowering the basal rate as you go on through the day. The other benefit you can get from the basal therapy is one. The second benefit in boluses, you have different ways of giving boluses, and we'll come to this also. So again, comparing both here, you customize the boluses based on ratio. You measure carbohydrates intake, you measure your blood sugar, and you enter the pump. We calculate these ratios. So this is one of the ways when you give the bolus. If you have quick-acting insulin, even the new nice analog, it will give you high level like this. So a lot of times my patient will say, if they're going to a reception or wedding, they will have a little snack in the beginning, then they will have a little, maybe some drinks, and then a main dinner and some dessert. That also happened in Ramadan when they start snacking and they eat big meal and small meal and sweets after that. And so that goes for 2 to 3 hours. A lot of them diabetics say, how much insulin should I give? Can I give, some patient will give 4 shots, so small with every part of their meal. This is an issue also for gastroparesis patients. They absorb insulin They absorb glucose different ways at different days and different food. It's also important for high glycemic versus low glycemic index. The absorption rate is different. In an injection, you can only give one to cover that one meal, and it goes high and low. But with pump therapy, you can program the bolus the way you want. Well, we ask patients to enter how many grams of carbohydrate they will eat in the next 2 hours, and what is their sugar at that time. When they check it, it goes to the pump, and we program the pump that will give you the bolus, but instead of giving it quickly, you can give it in a different ways. You can give it dual wave, you can give it square wave, you can give it 2 boluses. They say 1 in the first hour, 75% in the second hour. So based on your meals, you can deliver different boluses in different forms, in different shape, the way your activity goes like. So when we work with patients with the pump, instead of giving the patient an insulin regimen and ask the patient to change their life around the injection, we do it the opposite with the pump. We ask patients, show me a map of your week. Tell me exactly when do you wake up, when do you eat, when you exercise, when do you do this, and how's your meal. And we put patient on this continuous monitor. We see how they profile them. Then we program the pump based on that profile. So the compliance rate and the response becomes a lot better because patients do not have to change any of their daily activities. All what we do is we program the insulin to follow their habit instead of forcing them to change their habits to follow the insulin. And that's what pump becomes very successful with this. Show me the map of your day, and I can program the pump exactly that your day will go, and I get a much better control because I can have that tool with the pump, but I cannot do that with injections. It's a way of calculating total insulin doses, way of calculating the basal rate. It will be on your website. Again, there's a formula, unless you start in the pump, you don't really need to memorize these. And there's a way of calculating the carb ratio, sensitivity factor, and correction factor. This is really a slide we'll look at. This is some of the information you get from downloading a pump. A lot of time, we struggle when we see diabetic come in. We're limited. We're just hostage to the information they give us. If we are just looking at A1C, especially for type 1 diabetic, it's not the end of the story. For complicated type 2 diabetes, again, this is not the end of the story. Especially for teenagers and children, we struggle. Sometimes I have children who come to my office and then look at their book and it's all 120s for the last 3 months. 120, morning, night, and then A1C will be 13%, but all his sugar in his book are 120s. So sometimes the patient may not give you the full picture. With the pump, you can pretty much know exactly what's going on. You know when this patient, for example, slept to sleep for 12, 13 hours, she eats at noon, and her sugar was really high after that because her sugar is so low because she had been not eating for 14, 13 hours. So she doesn't give herself boluses, and you can see the sugar goes up. These squares tell me the bolus, the time when the patient gave themselves boluses, because the patient may tell you, I give boluses 4 times a day, and I'm going to cover my meal, but this is 2 weeks data showing that the patient only took 7 or 8 boluses. So you can tell. I usually tell patients, don't lie to me. If I download your pump, I know exactly what you've done the last week. I know how many times you went to the bathroom. I know what TVs you watch. I know where you went out. I know exactly what happened in your life because everything in the download of the pump. Every single information a patient usually gets surprises. One of the really nice information that really help us with these complex diabetic, and we all usually get these very complex diabetic, is this day-by-day download. And this is, remember I told you, we put different basal rate program based on your activity. So I tell my patient, this will give me usually 2 weeks worth of data. So these 2 weeks, I'll say, listen, every Monday your sugars are high at night, or every Sunday, or every month. So usually this will tell me what's your sugar on dialysis day, non-dialysis day. What is your sugar on night shift and day shift? What does your sugar look like when you're stressed and having a fight with your wife, or not having a fight with your wife? I can tell also days when you're stress eating and a day when you're not stress eating. I can tell the days when you're actually eating at home or you're eating outside. Because it tells you all this information with downloading the pump. So you use all these tools to talk to the patient. So it will be a great education for me and the patient to work on a better regimen. We say, on that particular day at night, when you had 6 slices of pizza, your sugar went 500. Next time, either you eat less or you take the right amount of insulin. A lot of times, a patient cannot tell what they've done wrong to cause the sugar to be high, but with downloading this information, you could really get all the information. There's another way of downloading the pump, and it gives you really great information. Part of it is the blood sugar, the amount of carbohydrate, and did the patient give boluses or not. These are times when the patient did not use the pump. So you can tell on a duration how much the patient did not use the pump. And that's important sometimes for children, adolescents, that sometimes they just go to the room and disconnect the pump. You can tell exactly how many hours they did that. You can tell information here about the carbohydrates. I have patients who, her A1C is perfect on the pump, but her weight keep on going higher and higher and higher. And finally, when she admitted, we're looking at the carb intake, and this number, usually an average diabetic may get 100 grams of carb. Her numbers documented will be 900 grams of carb. And when I asked her what she do, she said that at work she's bored and she buy these huge bags of biscuits and cakes, and then she keep on eating. And every hour she eats and gets bolus. Has perfect sugar control, but with 35 pounds weight gain. Again, you can tell that information from how many grams she put, how many pumps she did. You can tell also the percentage of boluses versus basal insulin. A lot of time patients like to over-basalize. So to avoid using multiple injections of boluses during the day, they use very high doses of basal insulin to stay low all day, so they don't have to take shots during the day. You can tell that from downloading the patient. We need this bolus ratio to be around 40 to 50%. If it's lower, patient is over-basalizing. That means they will have a risk of hypoglycemia in between meals. So a lot of information to get from the pump. These are the numbers we program. We can program something also called active insulin time. For some of the patients, the opposite. We have patients who check their sugar 18, 20 times a day. They're obsessed with sugar and they bolus 20 times. I have a 75 years old female who liked her A1C at 5 and she liked to bolus 20 times a day. And with the pump, there's something called active insulin time. You cannot just keep on injections. For example, if the bolus with 10 units and an hour later she likes to bolus another 10, the pump will go back to the last 4 hours and calculate the insulin on board and minus it. So this is a safety mechanism with pumps so people cannot overdose on insulin. And that happens a lot. We see it in teenagers sometimes to attract attention from their parents. They overdose on insulin so they get low, so they get now the attention from the parents. We see it in the elderly sometimes. They do it also to get attention from the children. So some of these ways you are protected from these because the pump can tell what did you take the last bolus and minus these numbers. So I get a lot of benefits in terms of giving, downloading the pump, taking that information. The second part of the talk is talking about the insulin sensor. These are the continuous monitors that will send data to the pump. And not even to the pump, that you can actually use this data to get a lot of information. One of the ways is to get to this, what eventually we call it the closed loop, and we're getting steps better and better into getting close to the closed loop, where actually the sensor will send information to the pump, and the pump either will stop working or increase the work based on the level. So this is what everybody's looking for. We're not there yet, but we're getting closer. The more you check your sugar, the better. This is exactly what the patients give you number. They give you 4, even in the best scenario, your patient checking the sugar 4 times a day. We're talking again about type 1 brittle diabetic or brittle type 2 diabetic. We don't know what happened in between meals, so the A1C is high. Patients here, this usually happens. A lot of patients, they wake up in the morning with good sugar because they took a big basal dose. A lot of times they don't admit that they don't take anything for breakfast. And that's why their sugars go really high after breakfast and sometimes after dinner. Again, depending on the activity, the sensor, the continuous monitor, and it's really a nice, cheap device. You can put it on the patient for a week, and you come back, download it, and you get tons of information. You tell the patient this is what happened after breakfast, after lunch, after dinner, overnight. You can detect a lot of hypoglycemia. You can also prevent death from hypoglycemia with having C sensor, because they will beep when the sugar goes to a certain level, and you can program the threshold to be at high or low level, so you can prevent it from happening. So again, by getting that voice, you can prevent it from going too high or too low. And we got so many of these coming out. I don't want to get into so many different kinds. Again, there's so many sensors and pump, and again, it advances. The sensor data gets through the not through the capillary with the machine. The sensor gets it through the interstitial space. It is important to know, because the sensor is not a replacement of checking your sugar. You still have to check your sugar 2 to 3 times a day to calibrate the sensor, and there's also a time delay. By the time you get a number here, the sugar has been, you get a number probably 20 to 30 minutes later. So it is not important to tell you what's your sugar at that moment. It will tell you the trend. Is my sugar dropping or going higher, and what should I do about it? So again, that's a technology. The sensors are getting better. This is a Clark grid analysis. If you don't know it, Clark is a very smart man. I've met personally a few times. And this is how you actually look at the meter to see if the meter is good. By this, it should be over 98% in the A zone to have a good. Now, previous sensor had a lot of numbers in the B and C zones. The newer one coming more into the A zone. Again, the accuracy of these sensors are improving almost every year. The technology improving significantly. With the sensor, you get data like this, where you don't get any much from it. You can show it to the patient at a different time of the day. You can show it pies and columns, whatever the patient likes. Some people like to see these numbers. Oh, look at how many highs you have. And then you have them at a certain time of the day. You're low here, high here. So these percentages, again, educate the doctor and the patient about how good their diabetes is. It tells me a lot of information. This is actually a physician husband. She brought it because his A1C was 6.5%, but he's not feeling good. I have 2 minutes. This one actually, the patient was getting 100 units of insulin at night, and he was having multiple hypoglycemia for a very long time. And he wasn't getting any symptoms, 0 symptom of hypoglycemia, because he got the hypoglycemia unawareness because he has been getting these lows for years. Eventually, we looked at this, and it showed that he has this information. We use iPro continuous glucose monitor in Ramadan. We have almost 300 patient data now that we put the iPro during the month of Ramadan and do for at least a week. It can help me first tell the patient if they can fast or not, and show me a lot of people on insulin pump in type 1 can fast with less risk of hypoglycemia if you manage it right. It will tell me how to manage their pump, their doses, their medication, without the risk of hypoglycemia by having that monitor all the time. And also tell them when they have to break the fast because the sugar is trending down. So it's a great device for the Muslim patients in Michigan to help them. Again, we look at, and it also helps us to see what is the best regimen. And hopefully we collect all the data, we can make some sense out of it. It tells about certain medication, what happened before and after you start the medication. So the sensor tell you the accuracy of your management. You put it on for 3 days, you change management a month later, put the sensor on, it will tell you if the patient do it or not. It will tell me this Vigo device, which is a disposable pump, before Vigo and after Vigo. So it tells you again what is going on. These is again more of the newer, this is the newest, the Minimed 670 system. That's the closed loop, just came out probably a week ago, approved in the United States with the sensor talk to the pump. So again, so we're getting closer and closer where the pump can actually tell when the sensor will send to the pump and the pump will stop working in these patients. So I only have 30 seconds, so I'll be happy to stop the interruption. Thank you very much for having me here, and I'm sorry it was too complicated.